Hi,
Hey,
good.
everybody.
I thought we were starting at 8.
I thought so too. I don't know exactly what happened, but here we are.
Okay.
All waiting to get into the room. I don't know exactly what the story is, but it's good to see everyone. Good evening to everyone, and happy Pesach Sheni. We are back again. So Pesach Sheni, we have Rona Sheni. Rona Novick is here with us for a second time. And Rona, I have to tell you, I enjoyed your talk so much that I gave over parts of it to my staff. And I then modeled my next session after you, and I came prepared with the whole slideshow thing, and I felt so much better prepared. So thanks for showing the way for that.
Pleasure.
And Rona's here tonight to give us some help, some insight, and a little bit of guidance on dealing with the craziness that we are all going through now with our students. And maybe we will go back into our classrooms getting a little more prepared for everything that's ahead. So thank you, Rona.
My pleasure. I'm hoping it will let me share my screen. Looks like yes. You all see that? Yes?
Yeah.
So, slideshow. Okay. So, I was asked to address student mental health challenges months ago before COVID-19 came. So just, to give us a context, realize that student issues with their mental health do not come only in times of crisis. This is a chronic or long-standing issue. And the takeaway that I want you all to leave with tonight is that nobody expects educators, mechanchim, mechanchot, to be therapists and to be mental health practitioners. But my feeling as a mental health practitioner, and I'm a clinical psychologist as well as being the dean of a graduate school of Jewish education, my feeling is that if our schools are not places of promoting mental well-being, then the risk is that they're places that are promoting mental health. We have to be contributing to children's growth, not just academically, not just socially, but also their mental well-being. So we have to, as we begin to think about this issue, we have to consider, this is what my plan is for today, and it's always a problem if the pictures are in the way, I can't read the slide. I want us to consider what common beliefs are about mental health, our own beliefs, parents and families' belief, and even students' beliefs, because they're going to impact how we work with students now and always. I want us to consider what educators can, should, and should not do. And then we'll look closely at depression, anxiety, and inattention as symptoms and syndromes, and how trauma and our current situation is impacting all of that. And finally, we will get, don't worry, we will get to strategies. What should educators do to support mental wellness? So here are some things that you may have heard. Maybe you even carry these in your own head. You think about this when you think about mental illness. And I apologize, some of them say he, because I've used these slides in co-ed settings as well. Students who are not doing well, they're just lazy. Or, of course she's sad. Look what she's gone through. Her parents are getting divorced. Or, there was illness in the family. Of course she's sad. It's not mental illness. It's just dealing with life. We've also heard all too often, it's all in her head. This is all in her head. And by the way, that is said not only about mental symptoms, but it's also said about things like stomach aches and physical ailments. There's a special name for physical illnesses that are particularly triggered or worsened by emotional factors, and they're called psychosomatic. A psychosomatic illness is not in your head. It's just affected by your head. It's not a fake stomachache. Ulcers are psychosomatic. They're very real. If you did a biopsy, you would see the ulcer, but they're made worse by stress and by psychological phenomena. We'll also hear things like, these kids should just tough it up. You know, in my day, kids didn't have anxiety disorders and they didn't have attention problems. They were tough and they just made it through school. And then again, we also hear this isn't a real illness. And we'll talk about why some of these myths and these beliefs, which are going to get in our way. And I could add another myth here, and it's not a myth, a belief that we can't acknowledge this because of the stigma, because it will impact our child or our family negatively. So let's pretend it doesn't exist. Some of the issues and questions that we have to consider as we explore is, how is mental illness different than mental wellness different than physical wellness? So they are different in certain ways, in that for many areas of physical wellness, our assumption is we've got ways to check. We can take our blood pressure and we can take our temperature, and those are windows into how our physical health is doing. When we go to the doctor, they put a stethoscope, they listen to us, they look in our ears and our nose, and based on those observations, and in some cases on actual tests, blood tests and urinalysis, they make a diagnosis, and based on that, they then prescribe a treatment. Mental health and mental illness have no hard and fast test. There's no blood test for depression. There's no blood test for anxiety disorder. There is no test for attention deficit disorder. There's no lab you can go to and say, here's some serum, can you check, do I have it? Did I have it? Am I immune? It doesn't work that way. And one of the reasons it doesn't work that way, and that's why we have this graphic of the brain there, our mental well-being is governed by 3 chemicals that operate in our brain and only in our brain: serotonin, norepinephrine. Oh my gosh, I just went a block. It'll come. And norepinephrine, serotonin. It'll come to me in a minute. I just lost the third one.
Dopamine.
Thank you. Dopamine. Thank you. How dopey of me. I lost that one for a minute. Those chemicals cannot be found any place but the brain and the spinal cord. And most of us do not want to have a spinal tap to determine whether we're depressed or not. And quite frankly, the spinal cord is the brain's garbage disposal. So what we find in the spinal cord is not exactly the same as in the brain. It's the byproducts of what the brain does. So we do not have a way to study what's happening with these neurotransmitters, which we know when they're out of balance, that's what causes mental illness. It's a biological phenomena, exactly the same way that diabetes is caused when insulin and insulin production in the pancreas is out of balance. And by the way, we can't anymore wish our pancreas to make insulin than we can wish our brain to make serotonin or dopamine or norepinephrine. So we have this notion that it's different because we don't have the techniques and the technology to study the living brain. But in some ways, it's really the same. Mental wellness and mental illness are driven by the same chemical processes, well, unique chemical processes, but by chemical processes in the same way that physical illness is. We also have to, as we discuss this, realize that we are dealing, even in 2020, with significant issues of stigma. And if you think it is unique to our Frum community, I will tell you it is not. In the secular world as well, there is still a distinction. People used to be. I remember when I was in grade school in ancient times that, no one would say the C word. No one would talk about cancer as if it was somehow catching. And now people talk openly about being breast cancer survivors, about surviving, about cancer treatments, and etc. but you don't talk about depression. You don't talk about anxiety, not in the same way. Um, I put an assignment here, but I can't read the chat while I'm showing the slides. But feel free, while we're together today, I will come back to the chat from time to time, to type your questions and your thoughts in the chat room for us to review later. And many of you are probably muted, but also call out. I can't see everyone while I'm doing the chat, while I'm doing the slides. If you have a question, if something's not clear, by all means, interrupt me. What is an educator's role? And the pink are the things, yes, we should do, and the blue are the things that are not your job. And it's a good thing that it's not your job. You have enough to do as educators and as educational leaders and administrators. So educators never make a diagnosis. In fact, in New York State, in public schools, it's illegal. An educator cannot say to a parent or write somewhere on a report card, this child has attention deficit disorder, or this child is depressed. Making a diagnosis requires years of experience, careful observation, but a diagnosis is based on data that comes from the child themselves, the child or the adolescent, but also from parents and teachers. So while you can't offer a diagnosis, you're in an amazing position to observe and describe behavior. You can't say this child is depressed, but you can say, at the beginning of the year, she had lunch with 3, 4, sometimes as many as 6 girls. Now she eats by herself every day. At the beginning of the COVID-19 crisis, she was in all of our Zoom classes, participated and was active. Now, I see her not doing that. Or even at the beginning of COVID-19, she had enormous difficulty focusing on the instructions and would often miss some of the details in what I asked her to do. That's observing and describing. In the same way, it's never expected that educators offer treatment. We'll talk about how you can offer support and be health promoters and even mental health promoters, but it's not your job to treat mental illness. It would be unfair to expect you to do that when you have 20 other children in the room who also need your attention and a curriculum that is your job to teach. In terms of teachers' roles, it is also really important for you to protect confidentiality. Our neighborhoods, our schools, our communities are very insular. We have all kinds of connections. When we're in our buildings, the same woman who serves lunch sits next to the parent of the child in shul on Shabbos. The same person who answers the phone in the office lives next door to several children in the school building. That means that we have to really think carefully about who we share delicate information with. We have to educate our staff that we do not walk in the hallways and talk about what Shira is going through or what we heard that the psychiatrist said about Devorah. We have to be very, very careful and share information only when we have a legal release form, that a parent signs consent that you can share information. By the way, the parent has the right, they own the child's medical information, including mental health information. The parent has the right to refuse to share it with you. The parent also has the right to say it can be shared, but in one direction only. The teacher can tell, they can be a source of observation and description for the psychiatrist, psychologist, social worker, but I do not want the social worker, psychologist, or psychiatrist to tell the school anything. I am often in that position, and my apologies. I always feel terrible saying to a school, I'm sorry that I can't share with you what is happening in the sessions. As much as I think that might be helpful for you to know, it is the parent's right to decide that it's not shared. In fact, if I don't have a release of information and you call me and ask, are you seeing Mushka so-and-so in your treatment, in your therapy sessions? I can't even answer that. It is also not the job of teachers to predict the future. When parents ask you, will she outgrow this? Will this get better? How long do you think it will take till she feels better? Frankly, I can't predict that future either. But it is something that teachers can offer to create success opportunities, to say, while this student is struggling, whether it's related to trauma or long-term, how do I adapt teaching and the classroom environment that's going to build success? You know, in my graduate program, our faculty used to get together. We get together, used to once every semester, twice, 3 times a semester, review struggling students. And our students are teachers themselves, but some of them struggle in graduate work. And I've tried very hard, and I think we've been successful in moving the discussion from, I want to tell you about this very poorly. Someone who has discussion in the background, if you could mute your microphone. Thank you. So I've tried to move the discussion from this student is not doing well to what would we need to provide as a faculty? What kind of supports or adaptation or adjustment would allow this student to succeed? And that's what I mean by adapting our teaching and class environment to allow for success. Now, here's a really, really big challenge as we begin to think about both trauma-related and general mental challenges, is that the definition is so personal and unique. Depression doesn't look the same in everyone. And here's also where I like to think that physical disorders are so much easier, and like, oh my gosh, doesn't diabetes look the same in everyone? But just look at COVID-19 and how they keep on coming up with new symptoms and this very frightening new child disorder that seems to be related to cardiac syndrome. So it's personal and unique even in medical disorders. It's also a challenge that we use the same words for symptoms and for the actual illness. For example, when we are nervous, we say we're anxious. It doesn't mean we have an anxiety disorder. It means we have the symptom of anxiety. When something, has gotten us very sad and upset, we say, I'm so depressed. It doesn't mean we have the disorder that's called depression. And in the same way, we use these words. I'm anxious, I'm depressed, I can't sit still. I have ADHD, I have attention problems, I have nose dysphagia, I can't pay attention. We use all these terms very loosely in our discussion, and it makes it very muddy from what is the actual diagnosis, what's the real illness, and what's just us talking about it. Some challenges in terms of identification is that, and actually deciding, is this something that I need to be worried about, or is this just, Rifki's having a bad day? The challenges are that all of these symptoms, everything I'm going to discuss, exists on a continuum. It's not black and white. It's not my pancreas makes insulin, it doesn't make insulin. There is a continuum. So social withdrawal, for example. Well, there's total social withdrawal, there's being a little bit withdrawn, there's barely, a little bit, it's on a continuum. What we look for often are changes in baseline. So again, Rifki was normally very friendly, and all of a sudden, she's having nothing to do with other girls and seems to have pulled into herself. The challenge we have right now is, how do we understand the changes we are seeing in our students when those changes might be due to our whole world changing? And for those of you who work with adolescents in particular, how do we deal with changes in baseline when changes are they're the MO of adolescence. Adolescence is about change. I used to be friendly with Mushka, and now I'm not anymore because I've changed. I don't like those kind of girls anymore, and I like these kind of girls. I used to be really outgoing, and now I'm more quiet. I used to be more sullen, and now I'm bubbly, or vice versa. That happens in adolescence. Massive changes in sleep and eating habits, happen normally in adolescence. So how do we know when we see them, this is a sign of a problem or this is a disorder? We know also that environmental and situational factors make a difference. So when we know a child's family is lo alenu, going through illness or divorce or a family financial stress, and that child begins to show indicators that they are not doing as well, how do we know? Is it a real issue or is it the environmental stressor? And finally, some of the behavior and cognitive changes are not obvious. We don't, for example, if a child is not sleeping, is waking up multiple times in the middle of the night, or having enormous difficulty falling asleep, or waking up at 2 a.m. every morning, how would we know? We might see that they're tired in class, but we might not see it. And if a child is doing a lot of their work where parents may be helping them, how would we see that the child's powers of concentration are not what they used to be because parents are helping with the work? Some of this we just will not see. When we think about any mental wellness issue, psychologists talk about the triple response mode. That what we could really tease apart 3 strands that go into our health and wellness. One is the physicality of our body and our physiology, what we actually experience and feel physically. The second is what happens in our mind. How do we process, how do we process situations? How do we think about things? And I'm not just talking, when I speak about mind, I'm not just talking about academic mental ability. I'm talking about how we think about the world, how our thinking works. And finally, our behavior and our actions. And although these 3, pieces seem to be falling into the funnel in some order, the truth is the order is constantly random and changing. Think about how much your thinking impacts how your body feels, how your body feels impacts how you think. I know I had a miserable headache today, and I was not in the best mood because I had a miserable headache until some Tylenol helped. It's terrible allergies. So my body and physiology impacted my mind, and it 100% impacted my behavior because although I love to walk outdoors, I cut my walk short because the pollen was literally blowing all over the place. And I was concerned that my headache would be worse. And we can go in every direction. So what I've done here is to take a look at really the 2 biggest diagnostic categories, depression and anxiety. And let's look at how does depression impact our body, our mind, and our behavior. And these are just some general points. Obviously, again, it's not your job to make a diagnosis, but these are some things to look for. The depressed body, at least for adults, tends to be slowed down. It's more lethargic. Think about times in your life when you've struggled with sadness. You don't feel terribly energized. And that often leads to both sleeplessness and oversleeping. Now, interestingly, for children and adolescents, sometimes depression leads to the opposite. It leads to agitation, to agitated behavior, to chicken without a head syndrome, running around frenetically and not being very focused, which connects to the next piece. In depression, both the syndrome and the symptom, when we're feeling depressed, our thinking is not at its best. It's slowed down. It's a little bit like, trying to walk through mud. And the characteristic of depressed thinking is that it's filled with pessimism, self-blame. For children and adolescents, instead of self-blame, there may be focus on others in the form of anger. And we find that individuals with depression have greatly depleted concentration and memory. For us, those of us in school settings, that means that learning and grades are going to suffer. There's no way to do as well in school when your thinking is slowed down and when your memory and concentration are impaired. And in terms of depressed behavior, it is very common to see social and other withdrawal. Part of this relates to the mood that goes along with depression. And part of that mood is a kind of dulling or inability to enjoy the things you usually enjoy. So if usually I love talking to my friends on the phone, but I'm not enjoying that so much, then of course I'm going to withdraw a little bit and I'm not going to call as often. If usually I love, I don't know, walking with friends, I'm thinking about, how do we do all of these things with social distancing, but now I'm not enjoying that so much, well, then I'm going to withdraw and not do it. But the other behaviors we see sometimes have to do with eating as well as sleeping. And here again, we see both decreased eating, loss of appetite, but also for some people, overeating. And the final depressed behavior that we have to be very concerned about and think about is self-harm, which can be anything from superficial cutting that some students begin to engage in, sometimes because of depression, sometimes it is not related to depression, but other types of self-harm can be much more serious and can include suicidal ideation, thinking about suicide, or even attempting and planning for suicide. Nope, I did not want to do that. Let's look at what our mind, our brain, our body, and our behavior look like when we're anxious. Think about when you're anxious. Nowadays, that's pretty easy to think about because we all have a lot making us anxious. If you want to do a really interesting experiment, ask the people in your family that are your biological relatives. It runs in families, and it even runs in Ashkenaz cultures, in regions. Anxious bodies can have racing heartbeats, have sweaty palms, experience muscle tension, headache, butterflies in the stomach, feeling nauseous, feeling sweaty, feeling weak, feeling lightheaded. All of those are ways that people experience anxiety. And again, if you ask your mom and your children, they probably feel it the same way as you. Ashkenazic Jews are gut and cardiac warriors. We get agita, just like the Italians. We get indigestion, heartburn, and we have cardiac symptoms, racing hearts, high blood pressure, sweaty palms. People of German origin, Yekis, are more likely to have skeletal muscle problems, muscle tension and backache. It really does, the research does show that it runs in, it follows genetically from where we come. Our bodies are kind of wired to be anxious in a particular way. And knowing, by the way, how anxiety feels in your body is going to be really helpful for our students so that they understand when they go in to take a test or when they go for a job interview, or if they're old enough when they start dating, that, oh, this is how my body feels when I'm nervous. I'm just a little nervous about this. That's okay. And what are some strategies that can help me manage that anxious feeling in my body? We'll get to that tonight. An anxious mind, like a depressed mind, also does not have the best concentration. It's overwhelmed with thoughts of worry, catastrophizing, and something called hypervigilance. Let me look for every possibility that there was a germ. Did somebody sneeze? I think I heard a cough somewhere. Oh my gosh, the COVID germ is coming to me. If that's how I'm thinking, if that's what's taking my mental energy, how can I learn? The anxious mind makes irrational connections. It says, well, the last time I wore the blue mask when I went outside, I came in and I was coughing a little bit, so I can't wear the blue mask anymore. Even though we know that that's not the reason. And finally, what does an anxious body do? What's our anxious behavior? the most common way that we deal with anxiety, because the human being hates feeling anxious. And so what do? When we're faced with something that makes us anxious? We avoid it. If I don't like speaking in public because it makes me anxious, which thankfully it does not, because it's my livelihood, then I avoid public speaking. If I'm afraid of the dentist, then I avoid going to the dentist. And guess what happens? The minute I avoid what I'm afraid of, I feel so much better because I don't have to face it. The problem is for children and adolescents, if they avoid things like asking someone to play with them or public speaking or taking a test, they never get to learn how to cope. And they never get to learn that, you know what, it wasn't so terrible. Avoidance can have social components, and sometimes it can have that kind of superstitious ritual behavior. I can't wear the blue mask. To take a test, I need my purple pencil. That's the only way I can pass. That's what I mean by ritual behavior. How has the trauma, the crisis that we are currently living through, impacted all of this? So first, let's look at immediate impact. When we first had to take to our homes, and we couldn't go to shul, and we couldn't see our friends, and Pesach was nothing like we expected it to be. People's mood was anxious and perhaps a little bit irritable and sad. These are typical responses during heightened crisis. I just had a colleague yesterday tell me, sleeping doesn't feel like sleeping anymore. It just feels like a nap. I never wake up refreshed. And I think many, many people I'm speaking with are talking about how difficult it is to sleep when you have so much weighing on you. They're talking now about the COVID-19 15, the 15 pounds that everybody is gaining because we are all at home with the kitchen right there and we are eating nonstop. So definitely it's impacting eating, although I don't know if any of you have had this experience because usually I'm a big eater, but I can think of a few times in my life when intense trauma and crisis, intense loss and sadness, and really my appetite was gone. There was nothing that I could or wanted to eat. And in the midst of an early impact of a crisis, we can have fuzz brain. We're not thinking straight. We have decreased memory and concentration, decreased attention span. So many people are telling me, adults and children, that they're just not accomplishing what they would have been accomplishing if life were normal. And some of it is, yes, I'm sitting at my dining room table. I don't have all my things that I have at work. But some of it is that our brains are just not, they're not available to us because part of our brain is dealing with the crisis. And behavior in crisis can be agitated or lethargic. There could be social withdrawal or over-engagement, calling people endlessly. And for children, it is very, very common in trauma to see regression. A child who was sleeping independently, who now wants mom and dad in their room. A child who had stopped thumb-sucking, who's now doing it. Nail biting was done. They're back nail biting. My 87-year-old mother has told me that she's biting her cuticles. It's because she can't go and have her nails done in the salon. And so she is back to an old habit. Should live and be well. It should be the biggest problem we have. In terms of the impact of trauma in an ongoing way, we know that even when trauma is distinct, like Hurricane Katrina, the hurricane hit, we had the aftermath, we rebuilt our home, okay, we're done. Even when it's a trauma like that, there was a tornado, we rebuilt, we're done. There was, God forbid, a shooting, a violent act, the person is in jail, it's done. We know even when a trauma is past, there are ongoing effects. And right now, one of the problems we have is because COVID-19 is so unpredictable, because we do not know what the future holds. I've been saying to people, we are not dealing with post-traumatic stress disorder because we're not post. We're in the middle of the stress and the crisis now. And so what we are seeing are the acute effects of the trauma, but we are going to begin to see some of these as well. One of the ongoing effects after trauma is to have triggers, to have things that make you re-experience it. It could be a visual. I saw something, it reminded me of that time. It could be a smell. It could, by the way, taste and smell are very powerful triggers, more powerful than visual and auditory cues. So someone who had a car accident and there was the smell of gasoline will have enormous response now. When they go to the gas station and they smell gasoline, it takes them right back to it. One of the things that happens is that we start avoiding the things that make us nervous and the things that remind us. I've already talked about regressive behavior, anxiety and depression, and a big one is hopelessness. I believe that one of the things that our young people, particularly high school students who had been looking forward to this year as their terminal year, their year of senior programs and graduation and trips, and those who were going on to post-high school programs or who were going to travel are feeling like it's never going to happen. It's lost forever. I don't know when this COVID stuff is going to finish. And there is a real sense for those older students of, it's hopeless. It's just, is this ever going to get better? And I think we ourselves have to check, our own feelings, because it's difficult, as the news tells us that, well, at the same moment that we hear there's movement on a vaccine, we hear there could be a second wave. So challenges in the current virtual reality and the fact that we are not with our students live in person. And for many of the Chabad schools, you are never with your students live in person, for the Chabad online schools at least. But we have less time with students overall. Many schools, because of the current crisis, have decreased the hours of the school day because it is just too long to have students from 7:30 or 8 in the morning until 6 at night to be either on their phones or on their computers. It is harder to read nonverbal behavior online. If a girl is sitting in my classroom and I see her every day, I can notice that she seems different this past week. But it's harder when you're a little square. And by the way, I learned this week that there are students who have figured out how to change their name in Zoom. And their name is now changed to trying to connect. So that all you see is a black screen and they're off having, having lunch. And that's their way of kind of ditching out of class. At any rate, God bless them. They will always come up with ways around teachers. We've lost all our schmooze time. Think about all of the informal ways we connect with students in a brick and mortar school building. We pass in the hallways, we grab a minute here, we grab a minute there. When we're not in the building, it's much more difficult to say, could you, don't hang up from Zoom, stay a minute, I just want to talk to you. I actually tried to do this with a faculty member at my meeting yesterday, and it took like a good 10 minutes to get everybody else out of the Zoom room. Could you log off? And then it was so public that it wasn't so comfortable to have the private conversation. It's also difficult for us to define right now, as I've said, what's normal. How do you judge social withdrawal when nobody can be with their friends other than on the phone or online? And how can you assess change when we've all experienced such a massive change in our world? So I've talked about it, anxiety, and I've talked about depression. I have to talk about inattention. There are some things that overlap, but anxiety disorders, by the way, the actual disorder, the mental disorder, are the most common disorder in children. Most people think that's not the case. They think it's attention problems, but that's not true. It is anxiety. And there are some issues that overlap. There also are a lot of situational factors. Think about times when your attention wanders. And I always think about this example. When I'm fortunate enough to be in Israel and I'm riding the bus, my Hebrew is pretty good. And so I can eavesdrop on conversations I hear around me. and I pick up a word here or there. But my Hebrew is not good enough for the news on the radio. And the minute the news comes on the radio, my attention is gone. I don't try. I know I can't make sense of this. It's as if I could just as well be listening to a Japanese news report. I can't make sense of it. And so my mind goes. So sometimes when we think of students who we're wondering, do they have an attention issue? It could be a learning issue. It could be that they're not attending because this material is so far above them that they just can't process it. So it's just one thing to think about. There is a real disorder called attention deficit hyperactivity disorder, ADHD. It's a real disorder. It again has a real chemical imbalance that we know occurs. We can't test for it, but it requires specific criteria that include problems with attention, impulsive behavior. Impulsive behavior, by the way, could be verbal, calling out, interrupting people, and hyperactivity, which may or may not be present. And it has to have started by the age of 7. You do not develop ADHD at 20. You don't develop it at 15. You may have a teacher you don't pay attention to when you're 14, but that's not ADHD. That's a bad match between you and the teacher. The medications are very different for ADHD than they are for dealing with anxiety and depression. So let me move to interventions, and we'll talk a little bit about medication. And I want to consider when to refer, what the medication options are, not because you're ever going to medicate, but just so you have a sense of what's going on. Then universal approaches, how you could help everyone in your classroom, not target those with particularly who are in distress, and how you can use interventions that are cognitive and ones that are physical, focusing on physiology, and ones that focus on behavior. So thinking about referral, you have a whole bunch of questions that you have to answer. When do I refer? When is it an issue? When do I know that it is a serious enough problem? Now, again, if there were no issue of stigma, if there were no issues of COVID-19, if there were no issues of money and cost, I would say, we don't ask when we should refer our children to the dentist. We want them to have healthy teeth. They go once a year. I actually have a patient who once a year on her birthday, she says, I'm treating myself to a session with Dr. Novick. It's my annual checkup and my chizuk. I just like to think about how I'm doing. And this is the place I give myself to do that. I think it's such a great idea that we have mental health checkups, not that it's only that we see practitioners when we're ill. By the same token, I think that we're now hovering at about 80% of children with mental distress, mental illness, will never see a mental health professional. And part of that is, in many places in the country, there's no one available. One of the things that COVID-19 may make better is because now all of us are doing telehealth and teletherapy, insurance companies may be more open to supporting it, patients may be more open to using it, and that will give more access. So there's no easy answer to when. Again, if I had my druthers, we could have easy conversations with children and parents saying, listen, go. Find out what they say. It could be that I'm all wrong about this and that this is nothing we should be concerned about. But I'd hate to miss something if there's a way that we could be helpful that we're not being helpful. Then we have to think about to whom. And I think one of the most important thing a chanchot can do is generate a Rolodex, whatever you call it, a computer file of good practitioners that you feel comfortable with, that understand your girls, understand your students and your families, know their field, and can do right by you. I think it is in some ways less important whether it's a psychologist, psychiatrist, social worker, unless there's a medication consideration, because only psychiatrists can provide medication. But the person's training, their mental health hashkafa. I'm a cognitive behavioral therapist. I do short-term work. Some people are more psychodynamic. Some people are family oriented. Some people use dialectical behavior therapy. There are different approaches. Knowing what approach someone uses, which you can often get a sense by talking to them, and ask them. And anybody who says, well, I can't tell you what I do in my office, I wouldn't refer to them. Then what? Okay, I found one of the 10, 15 professionals that I refer to often that I have a good working relationship with. I'm going to refer to. Then what? What's your role? Your role, as I said before, given permission, is to share observations and information. Because frankly, the mental health professional is not going to see this patient more than once a week at most. And you're going to have much more contact. So you're the eyes and ears that can have a sense that whatever is being provided outside of school is working, is not working, is helpful, is not helpful. By the way, the mental health professional also can be a resource to you. I know that when I have a release of information and when a school calls and says, well, how should we handle it when Sippy does this? What should we do when she refuses to do that? I see it as my job as a mental health professional to work together with the school to help problem solve and brainstorm what are the options. What about medication?
Sorry, can I just ask, how does that work in terms of like permission? Like if I know a student is seeing a professional, I'm allowed to call up that professional and ask questions, but we said that you can't release any.
You can do whatever you want. You can call, but I would always get the parents' permission, and technically the professional should not speak to you unless the parent has given them signed consent that they can.
Okay, so you're saying it's in a case when everybody is on board to work together.
Correct. I mean, I will tell you, it's very frustrating to me that there are times that I think I could be helpful to a school and I have information that would be helpful, but the parent will not allow it being shared. By the same token, I could tell you horror stories of when parents have signed a release, have allowed information to be shared in order to help the child succeed. And then again, a school secretary winds up telling friends at a Shabbos table, did you know so-and-so is taking medicine? Did you hear? Oh my gosh, that whole family's crazy. That kind of, I mean, it's, first of all, it's Lashon Hara, but that kind of breach of confidentiality in our schools is what contributes to parents feeling uncomfortable with sharing information between the mental health and the educational professionals. Okay, here's the challenge with medications. As I said earlier, there's no biological markers. We can't take a blood test and say, oh, you've got ADHD, take this medicine, we'll take the blood test and see if it's worked. There are various types available, and most of the medicines that are used for anxiety for children and for depression for children fall into a class of drugs called SSRI, selective serotonin reuptake inhibitors. It's just a very fancy way of describing what they do in the brain to deal with the chemical imbalance that causes anxiety and depression. Those SSRIs take 4 to 6 weeks to work. They are not a medicine you take on Monday to help you do well on Tuesday. And if you miss doses, you're not going to have the full effect. So you need to build it up in your body and in your bloodstream. It needs to stay working, and you need to consistently take medicine every day. The medicines in lahavdil, in contrast, for attention deficit, there are many medicines available for attention deficit that do work much the same way that Tylenol does. You take it when you need it. It's in your body for about 4 hours, then it's gone. It's washed out. So if I don't need it on Shabbat, then I don't take it. If I need it because I have a big test coming up and I really want to study well, then I take it. But there's no requirement that I take it all the time. For that reason, I tend to be much more encouraging. I'm a psychologist. I can't prescribe, but I'm often working with families around, should we consider it? I'm often much more interested in considering ADHD medication for a child, because we'll know in a week whether it's making a difference or not. We'll know in a matter of days if it's helping. It's not a huge investment. And I always think about the parent of a 6-year-old girl who I was doing testing because her reading was way, way below grade level. All of her academic skills were very below expected. And there was a consideration of whether she needed to be placed in special education outside of a Jewish setting. And I did the testing. And at the end, I said to the father and the mother, I'm puzzled because I can't tease out whether this is a learning difficulty or an attention problem. I really can't. And so at times I would tell you she needs medicine. And at times I would tell you she doesn't, but I can't tell you. And the father said to me, if I do not try her, if I don't give her this chance and try medication, go see a psychiatrist, have her evaluated, and do a trial, I could, when she's 16, be kicking myself. Why didn't I do it? When for so many years she struggled and she was held back. If I'll know in 2 weeks, wouldn't I want to invest 2 weeks of her life now to find out the answer? Now, that's a very simple way. It always stays with me. But there are negatives to medication. Obviously, there's stigma, and that bothers not only parents, but sometimes it bothers children. They do not want anyone at school to know that they're taking medicine. I know of one family where the son didn't want his brothers to know that he was taking medicine. There are side effects. Tylenol has side effects. Motrin has side effects. Every medication has side effects. The side effects of attention deficit disorder medication after 2 weeks are relatively minimal and nuisance, although there's a very small set of children who have long-lasting side effects even when you stop the medication. It's unclear if it's from the medicine or if it would have happened anyway. The side effects of the SSRI, the medicines for anxiety and depression, are a little bit more troubling. They're a little bit more annoying to people who take the medicine. They can cause weight gain. They can cause dry mouth, which is very uncomfortable for students. And especially if schools don't let you have a sucking candy or chew gum, it can be really uncomfortable. And you don't want anybody to know that you have dry mouth. So you don't want to take the medicine and then you'll have dry mouth and everyone will know. And for adults, there is an impact on sexual behavior and sexuality, not relevant for children. But there's an issue of compliance. How do we get children who are inattentive to remember to take medicine? How do we get children who don't like the side effects to take medicine? How do you get children who are depressed and hopeless to take medicine? But here's the plus. For some students, they really make a huge difference. And I think that, as educators, as parents, as professionals concerned about children, we really need to think about how do we decrease suffering. And we need to think about the fact that for students, losing 6 months of their lives because they suffered a depression episode, losing their second grade learning because they're struggling with attention, that really matters. At my age, if I lose 6 months, the next 6 months are the same. There's no developmental task I have to master. There's nothing that I'm missing from that time period. But imagine taking a girl out of the social world that she's in, not like now, because we're all out of it, but imagine taking her out, social withdrawal, she's depressed, she won't engage, she's not connecting or talking to anyone. Imagine that for 6 months. How hard is it for the group to accept her back? Imagine someone missing 6 months of schoolwork because they were too depressed to function or their concentration was too poor. It's so hard for them to catch up. So I often err on the side of, if a psychiatrist feels that this child is a candidate, let's try it. And again, it's really good that I can't prescribe medicine, because when I advocate for parents to consider it, I say, listen, it's bad for me. It would be better for me if medicines didn't work. It's bad for my business because I can't do anything with medicines. So if I'm saying it, then maybe you want to consider it. So let's move from the things you can't do to the things you can do. How do we help all students build their social emotional skills? And I'll get to that in a minute. And the other way that we do universal prevention is we actually teach students about mental illness and mental health. I'm assuming that your schools teach about health, that you teach about, right now, you teach about washing your hands and germ prevention. But I'm assuming you probably teach about healthy eating and nutrition. And you probably teach about accident prevention and wear a seatbelt when you're in a car and how we're safe. Well, we should also be teaching about mental illness and mental health. We should be teaching about what anxiety is, what depression is, how many people get it, how common are these disorders, who does it happen to, what does it look like, what are the symptoms, etc. But in addition to directly teaching, here's what mental illness is and here's what mental health is, we are engaging in universal prevention whenever we build students' social and emotional skills. I happen to love this graphic. I apologize, there's so many words on it. It's New Jersey just released their, last year I think, or maybe it was 2018, their standards for social emotional development and the substandards. And so if you look at the 5 items across the top, self-awareness, self-management, social awareness, decision-making, and relationship skills. If we were to do any or all of these as part of our school day and part of our teaching, I actually hope that every single school day as part of your teaching, something on this chart is being taught, then believe it or not, you are preventing mental illness. Let's look, for example, let's look at self-awareness. Look at the first thing.
Would it be possible to get a copy of this?
I can send you the slides, sure. But this is available on the New Jersey, if you just Google or go to the New Jersey Department of Education website. It is the New Jersey Social Emotional Learning Standards is what it's called. So just recognizing one's thoughts and feelings. Think about all the opportunities we have during the day to ask students to take their temperature. I don't mean their physical temperature. I mean their mood temperature. How worried are you? How anxious? On every assessment we give, whether it's a test or a paper, right on the bottom, how anxious were you? Look at the last thing in that column, recognizing the importance of self-confidence. How confident were you? How good did you feel about your presentation? Every time we do these things, we are helping develop our students' skills of mental wellness. And then look at things that typically we think of as purely academic, like in the self-management, the last point here, identify and apply ways to persevere or overcome barriers through alternative methods to achieve goals. How often as educators do we say, if you get stuck on problem 9, put it aside, go to 10, see if doing 10 gives you some ideas, and you could come back to 9. Remember, take deep breaths, tell yourself, if I skip one, it's okay. It's not the end of the world. We think we're teaching an academic skill, a problem-solving skill, but we're really building mental health. And by the way, we do it even more when we are transparent and obvious about it. And when we say, you know, girls, you know how I told you to skip problem 9 if you're stuck? That's true in life. It doesn't just work for math. In life, there are going to be times when you come up against something that is hard, and you have a choice. You could let your worries get the better of you, or you could take a deep breath and move on through. Okay, I'm racing so that I know we finish on time and we have time for questions. What's on your mind? Cognitive interventions is helping our students be more mentally healthy, developing their mental resilience by helping them discover, uncover, and change what plays on their internal, I'm going to date myself, phonograph. Because, you know, those of us old enough, records used to they would get stuck, and you would hear the same thing over and over again while it skipped. I don't know if that happens with digital technology as much. So I don't know what's a good metaphor. I always say that, you know, on your playlist, you only have one song. And that's what happens in anxiety and depression. Our playlist shrinks. And instead of the, you know, things are wonderful and it's a beautiful world, I have only playing all the time doom and gloom. There are certain negative thought patterns that are chronically associated with anxiety and depression. I've given you examples of them here, and let me define what they mean. Blaming is obvious. You know, it's all her fault. She did it to me. Forever thinking, the way it is now is how it is always going to be. And if the way it is now is problematic, then of course that's a very anxiety-provoking or depressive thought. Catastrophizing, it's taking something and making it into the end of the world as we know it. Oh my gosh, we can't have live graduation, and this is going to ruin my entire life. Now, I know that that's genuine and that students really feel that way, and it is a very real loss for them. Some of the things that they are losing now are very real, and we have to validate and say, it is pretty terrible, and I feel really bad that your class is not going to have it. Let's put our heads together and think about how can we make it special? How can we do this? I'm going to hold up because I'm writing by hand graduation cards to all of my graduate students who are graduating, because some of them after a 2-year master's degree, some of them after a doctoral degree, 6-7 years of learning, cannot come together and get congratulations from me in person and be, you know, congratulated by their family and friends and professors because we can't be together in a group. So that's an example of thinking about something, a new way to do things. Anyway, another negative thought pattern is binocular thinking. You know, when you look at in a binocular, it makes a small thing look much bigger. Problem 9, I didn't get problem 9. That's it. I'm going to fail this test. I'm going to fail out of school. I'll never get into high school. I'll never have a shut-off. My life is ruined. That's taking, you know, question number 9 and blowing it up. By the way, what happens when we flip binoculars the other way? Then it makes big things look small. That's the student who says, this test doesn't matter. Well, who cares about that? And that's problematic also. That's a child who doesn't have enough anxiety, and we need to get them a little bit anxious. And black and white thinking. You know that students are engaging in black and white thinking when you hear words like always and never. They never include me. They're always mean to me. You never call on me. You always, you know, pick on me. How do we help our students develop healthier thought habits? I've developed an idea that I call the 2-question test. First question we have to ask ourselves about, once we identify, this is a thought that's playing in my head. Let's take a real thought right now. Coronavirus is terrible. First question I have to ask myself is it true? 9 times out of 10, by the way, the answer is going to be yes, because most of our worries and anxieties, most of our depressive thoughts come from reality. They're based in truth. Is it dangerous to be out in the world right now? Is it true? Yes. Yeah, there's at least a chance that that's true. Is it dangerous for me to go grocery shopping tomorrow morning when the stores are a little bit crowded Erev Shabbos? Yeah, it is. But then I have to move to the next question. Is it helpful? Is it helpful for me to keep this thought running over and over and over in my head? Does it move me forward, or does it keep me stuck? Does it make me feel better, or does it make me feel worse? And here, most often, the answer to the question will be no. No, it's not helping me to think this way. So then, I agree. I have to do some mental housekeeping. I have to clean up my thinking. How do I shift my cognitive focus? There are 2 ways that we can do that. One is through distraction. A busy mind it's harder for a busy mind to worry. The problem is we've all heard our grandparents, our parents say, just think happy thoughts. We know that doesn't work. Happy thoughts are not strong enough to distract from anxious and depressed thinking. But mental activity that takes a lot of energy is. So if I say, start from 100 and subtract 7 and keep going till you get to 35. I don't know about you, but that would take a lot of energy on my part. Think of the tefillah Aleinu, and how many times in the tefillah does the letter Aleph occur? Oh my gosh, that would like be impossible for me to even do that in my head. But that's so, the point is, it's so mentally engaging that it does distract you, at least momentarily for short periods. But often we have to use a thought exchange process or even a thought argument process. So what particularly thought argument is very good for anxious thoughts. So an anxious thought, I'm going to fail the test. Is it true? Well, maybe. Is it helpful? No. A thought argument process is, it's kind of like what happens with Stone and Amara. Well, is there even a 5% chance that I won't fail this test? Maybe I could accept that there's a 5% chance that I will pass. Well, if there's a 5% chance, would I go to 10? Well, I think there's a 10% chance I could pass this. All right, I can argue that maybe there's a 10%. Another way of doing thought argument is to say, where's my evidence? As if I'm a attorney in court. What evidence do I have that I'm going to fail this test? How many tests have I failed before? Have I ever failed a test before? How likely is it? I've never failed before. Why do I think this is the test I would fail? This is all happening internally in our head. And thought exchange is exactly as it says. It's saying, I was thinking I'm going to fail this test. I'm going to now put on a different song on my mental playlist. And I'm going to say, and listen carefully to the different song I'm going to play. This test is hard, and I probably won't do as well as I usually do, but I'm going to try my best. Notice my thought exchange for I'm going to fail wasn't I'm going to get 100. Our brain will reject thought exchanges that are too Pollyannish and too perfect. Our brain knows we are far from perfect. And when we're dealing with something hard, our brain knows we can't do it exactly right. So coming up with a good thought exchange is a challenge. In terms of physical and behavioral interventions, how can we change our body and how can we change what we behave? So the way that we manage our body has to do with first recognizing our biology, that sleep, diet, and exercise fuel our machine. And if we don't give our machine fuel, it's not going to work well. So thinking about how we improve in those areas is important. We also can manage our body and our levels of both depression and anxiety through exercises like breathing and mindfulness and relaxation. And it's beyond the scope tonight for us to go into all of those, but realize that all of them are teachable and learnable behaviors. Let's do a very quick example. Put one hand on your chest up here and one hand on your belly and take a deep breath. Notice which hand moves. I can see some of you on the screen. I see some of you. It's this hand, your chest hand, that's moving. Well, that's wrong. You're breathing wrong. You're not breathing well for relaxation and for decreasing anxiety and depression. Because our diaphragm, which is down in our gut, is what pulls in oxygen to get our brain and our body have as much oxygen as it really needs. When we breathe up here, if you ever did Lamaze breathing, that's in your transition breathing. That's up here. It doesn't give you full oxygenation. It's for the moment of crisis, but it's not good long term. If you want to teach girls a quick and easy way to do this, also for young girls, they can lie down, put a lightweight book on their stomach, and take breaths in and out and make the book move. It's a good way to practice diaphragmatic breathing. And for relaxation, there are numerous approaches to teach relaxation to all ages. Children, I've given you the copy of a book, Relaxation Exercises for Teens, in the graphic there that I just found on Amazon. I don't have that book. And I have routinely now, when I work with teens, when I work with classes, I'll make a recording of myself doing a relaxation practice, narrating it, so that they can all take it home and listen to it on their iPods and on their phones, and they can practice. The last point I want to make is about behavior. And this is such a Jewish concept. I love dealing with from groups because we get this. We understand that even if you are depressed, if you act as a non-depressed person, you will be healthier. We have this concept in Jewish life. We do mitzvot, whether we have the kavanah or not, whether we have the right intention or not. It's still a mitzvah. We still do it. We have the notion in Jewish thought that if we do something long enough, even if we do it without feeling, that the feeling will be generated. And I had the experience when I was in graduate school. We actually did a study of depressed women. I was one of the therapists in one of three conditions. One group of women got traditional therapy. One group of women got medication. And the group I was with got what were called prescriptions. What were the prescriptions? We told them every day a behavior they had to do. Today you have to call 3 friends. Tomorrow you have to watch a comedy show. The next day you have to go with a friend for a cup of coffee. We prescribed non-depressed behavior. Our group did the best. The women did better with prescription to act non-depressed than they did with medication for depression. Acting in a healthy way helps us be healthy. Behaving as if I'm not a nervous wreck and I'm not horribly depressed, pushing myself to do normal, healthy things is good for making me a normal, healthy person. Okay, good. Thank you all so much for listening. I'm looking at the chat room now, so I can see the chat, and you can feel free to type things in the chat. But also, I want people to feel free to open their microphones and ask for clarifications, for questions. You're right that mental illness is so different depending on the sufferer, but it really is a little bit of a myth that we're used to what strep looks like, because I'm just thinking about my youngest child who